You all right?
Yeah, I'll just introduce you. Just as we open with day 2 today, we have a special treat. Today we have a guest lecturer who will speak to us on the important topic of community mental health, Doug Taylor, who will introduce himself. I'll just make this one comment, well, 2 comments. One, he may be the longest serving sessional lecturer here at CHC. He's been working here for 25 years and has a rich history in the area of counselling and with the Salvation Army. And so it's just a real privilege for us to have someone of the caliber of Doug Taylor with such a long-standing affiliation and even friendship with this institution. And we're just so blessed to have him share this morning time together with us. So that's all I will say. Can we just warmly make him feel welcome? Thank you for joining us here this morning.
Yeah, as Johannes was saying there, I've been teaching here at Heritage for about 25 years now as a sessional lecturer, and have covered a load of subjects during that time. Are you all first year or second year students? First year students still? Okay. Well, that's probably why I haven't encountered you just yet, but you may still encounter me somewhere down the track. I retired from my full-time job about 2 years ago. I ran the Salvation Army's counselling clinic for 25 years. My original background was in social work, and so we were a clinic that offered counselling of a whole range of areas. So in a sense, we were community mental health. Some of us were community mental health workers who worked there. You had to have a special kind of an extra kind of little qualification to be classified as a community mental health worker. It's probably not something you all want to think about yet. So are any of you actually doing any counselling already or working? You're all doing counselling? You're doing counselling, right? Where do you do counselling? Oh, at the church. Okay, all right, okay. Well, are you're not qualified yet, so you're not a member of PACFA or the Counselling Association or anything like that. Once you become a member of that, then they'll give you a pathway about how you can do some extra kind of things that will allow you to call yourself a mental health worker if that's the area that you might choose to go in. So have you thought about the areas that you'd like to work in? I know that yesterday you covered a whole range of things about the kind of things that are available in the community. Have you all thought about where you might like to work maybe in the future? Yeah? Okay. Are you all doing counselling? No? So some of you are counselling, some of you are what?
Bachelor of Social Science.
Social science? Okay. Mostly social science students then? Yeah? Okay. All right, fair enough. What I'd like you to do is maybe just, because you're not doing counselling, I suppose I could still ask you the question, because I usually ask students, why are you doing this? What's the reason you chose social science? As opposed to business or teaching or something else? What made you choose social science? And maybe counselling particularly?
For me, I really value meaningful conversation and meaningful relationship, and found that the richest part of my life and the most helpful part of my life in my own journey.
Okay. All right, fair enough. Anyone else?
I guess for me it was twofold. Firstly, that everyone was coming to me and saying, help me, help me, help me. But I didn't have the skills to help them, so they were going away and remaining the same, and I got fed up with that cycle. And the other thing was, personally, I found a lot of gaps in the system that weren't being fulfilled, and I wanted to change those gaps, whether it be with me changing policy to make those gaps be filled, or whether it be me working in an area that was able to impact that.
What sort of gaps were they that you've noticed?
Well, my middle child, he was diagnosed with autism when he was 7.
Okay.
So he was too old for autism intervention.
Okay.
But by the time he suicidal.
Yeah.
We take him to psychologists and that, and they'd say there's nothing wrong with him, we can't help him.
Yeah.
But it was because he was being bullied.
Yeah.
But there was no system for him to come into until he was 13 where he could go to youth mental health. So that whole primary school area, there was really no support out there besides chaplaincy for him.
Okay.
The other thing that I find really difficult is I'm what you class as a high-risk carer because I care for my mother plus 2 children with autism,
Right.
maybe 3. And there's a lot of support out there for the people, like the aged care or autism and disabilities and that, but there's nothing out there that I've found really for the carer.
Okay.
So, you know, with child safety and that, if you're a foster carer, you can send your child to respite and stuff. But if your child isn't high enough on to receive NDIS, you sort of fall through the gap a bit.
Okay. Are you familiar with the Carers Council?
I have spoken to Carers Queensland about where
Yeah.
my needs are at, and they've said to me there's nothing they can do to help me.
Okay.
So,
Really? Okay.
They can do stuff with mum, like send her to respite,
Yeah.
but if she refuses to go, and like even things like she's on a package, and that package supplies, you know, cleaning and all the everyday stuff.
Yeah.
But it doesn't provide for the loneliness. It
Okay.
doesn't provide for when she gets
Sure.
pulled up and she needs that reassurance.
Yeah.
You know, she's got no one to ring at 3 o'clock in the morning besides me. So, you know, I can go to bed thinking everything's fine, but that doesn't stop the phone calls in the middle of the night because
No.
she's up and in pain and scared.
Sure. Yeah.
So, you know, that's
Okay.
fine, but it's a gap in the system.
Okay. All right. I'll talk to you in the break because I think I might give you something as well that you might want to think about. Okay, who goes next?
I believe it's what I'm called.
So you are calling, did you say? Yeah?
I just feel that's what I'm called. I mean, a lot of it I've done been with the giftings and the personality testings, but and also just looked into the meaning of my name and just, yeah, always what I wanted to do. I just feel
Right.
I'm calling for it.
Okay.
Had prophecies and different things like that. So.
Yeah, okay. Interesting. All right, who else?
Mine's pretty simple, but I just wanted the skills to be able to help people.
All right. Anyone else?
I'm volunteering with youth and I wanted to get into that field. So I'm doing my Bachelor in Counselling, hoping that I can get into school counselling.
All right, okay.
I guess for me, when I was in school, I really hated school. I was never going to go to uni or anything. So it was my 3rd year out of school and I went to America for a year and as part of my visa I had to do some college course, so I just did it in sociology and I found it really interesting and I was able to understand it and I just really loved learning about it. So
Sure.
I thought, just why not
Okay,
learning about it?
right, okay.
Yeah, I came from more of a ministry background as well, and similar to some of the other guys, just looking to pick up more skills and utilise these giftings as well.
Okay, okay. I wish you'd all written that down. I guess it'll be on tape since you've all spoken it out and it's going to be recorded. And then look at it in maybe 10 years' time, if you could, and see whether you still think the same way. It's not uncommon to hear the answers that you've given for people who are in the beginning stages of doing this kind of work. The reality is that it's a challenging job to be getting involved in. And while some of you might feel you have a calling and you feel like there's a real need out there, at the end of the day it's also about what's going on inside for you, deep inside of you. And it's quite easy sometimes for us to think altruistically and not think, well, what about what's happening really for me as well? And a lot of people who go into the helping professions, whatever that might be, whether it's counselling or social work or doctors or nurses or psychologists, often there's a kind of a drive that comes from within yourself. And sometimes it has to do with your identity. So I'd encourage you to explore that area a little bit, and obviously today that's not a part of what we're about today. So we're going to talk about mental health, community mental health today particularly, and what that means. And those of you who might think that's an area that you'd like to work in the future, then give you a chance to think a bit more about what that might be like for you. How many of you in this class have encountered people with, and this is going to be an interesting question to ask you, mental health challenges? I'm going to put it that way. Okay. What's the difference between mental health and mental illness?
I think everyone has a form of mental health, but not everyone necessarily has mental illness.
Okay, that's a pretty good answer, yep. Yeah? What do other people think about that answer?
I actually find the term mental health being very, very raw, quite an oxymoron. It's a little bit like, we're studying mental health, but they've all got mental illness. You know me, not, I'm just saying it generally, but it's just like, to me, I find that term mental health, a bit opposite to what it.
Do you have physical health?
Yes.
What would be the difference?
No, I suppose in regards to, they'll say, look, this person has a mental health issue, and I get what they're saying, but to me, I totally understand we're going over a positive and negative, but it almost sounds like this person has a mental illness issue, you know what I mean? And I totally get where it's going, but it's just to me, when it first came out, it was quite like, oh, okay.
Okay.
I think when you get to mental illness, it's actually when you've lost touch with reality.
Okay.
So, you'd be depressed.
Yeah.
But when depression reaches psychosis, it becomes an illness. Something that may be able to be fixed with, counselling or.
Okay. Yeah. There is a little bit of blurriness between understanding those two terms, mental health and mental illness. And there was a point where, if I went back a few years, mental illness was the word that was used generally to describe everything, just about. And then the idea came on, no, it's a bit negative, and we need to start talking about mental health or mental health challenges. But in reality, I think your answer is a really good one, because we all have mental health as much as we have physical health. And sometimes our physical health can go wrong. 2 years ago, I had a problem with my heart, so my physical health deteriorated, and I had diagnosed with atrial fibrillation. So I had to have that correct. That was a physical health problem, but it led to a physical kind of a illness type problem as well. And I think in the realm of mental health, it's the same sort of area. So it's helpful to kind of think about it in that way. But we will talk about it a bit more. So, question I want you to write down the answer to is, what's the one thing you hope to gain from today's session? So if you've got a piece of paper there, or you're writing it on a computer, I want you to write down what you'd like to take away from today's session. Okay, has everybody got something? All right. So mental health workers is kind of like the term that I'm going to be using today as a generic kind of a term, but you'll see that it covers a myriad of types of professions as well. So you can be a psychologist but be a mental health worker. You can be a clinical counsellor and be a mental health worker. But so we're using it in a generic form, although we'll talk about some of the other fineries of that meaning as well. So one of the challenges of mental health workers is that they regularly face ethical challenges. And I guess, have you covered ethics yet in your courses at all? Any of the courses you've looked at?
Yeah.
Okay, so who can tell me what ethics is about?
Some do no harm.
Okay, that's one of the principles of, some of the ethics, do no harm, Ethics are really about principles that guide our practice in the way that we work with other people in terms of helping people, doing the best we can for them, and the principle of do no harm is one of them. So I'm starting it off with this way because I want to challenge you a little bit to start thinking about some of the finer implications of what it might mean to be a mental health worker. So here's an example. A therapist is seeing an adolescent for therapy. After several sessions, the client reveals that he is taking drugs. So should the therapist tell the boy's parents? So if you were the person helping that young boy and you found out that he had a drug problem as well, what would you do? As a mental health worker, working as a therapist.
I think it depends on the way that the conversation was going. And, I guess the other thing is the age of the adolescent, because if he's 18, he's an adult anyway, even though he's in the adolescent. It'd be a lot different to an 18 than a 13.
What if he was 16?
I think it depends on what kind of drugs he's taking and whether he's revealing to the therapist that he's taking it so that he can get help.
Okay.
Whereas telling the parents might not always be a good idea because they might condemn the kid rather than try and help.
Okay.
But at 16, you can go to a doctor, and a doctor's not allowed to disclose anything that's said to the parents.
Okay.
I think if the boy's at risk as well, depending on drug use, but almost like the therapist still has a duty of care, I believe, to the parents, to tell the parents.
I'm not going to give you the answers, by the way. I'm going to let you think about them. Here's another one. A psychologist teaches part-time. This is one that I've encountered personally over the years. Teaches part-time at a college in addition to providing private practice services. A student at the college begins seeing her for therapy, but is not a student in any of her classes. A year later, the student enrolls in one of her classes. What should she do? So what should the lecturer do?
Refer to someone else.
Sorry?
I think she should refer to someone else while she's in that position.
Refer to someone else? Okay.
I think she should also inform her bosses because there's a conflict of interest.
Okay. What is the issue with this particular case? It's another ethical kind of a dilemma.
It's a power imbalance.
Power imbalance, yeah. This one is pretty common, unfortunately, in Christian circles. That's quite hard to get around. This is one that we call dual relationships, where you have a relationship with a person at one level and you have another relationship with them at another level, and sometimes those two things kind of conflict with each other.
I think that even in this case, because both instances she's working in a professional capacity, it's a bit different to, a year later she goes to a church where they're both attending a church and she builds a relationship. That would be more a conflict of interest and than where she's working both in.
That could be even a bigger dual relationship issue, isn't it?
Because she's still working a professional relationship, just reporting it to her bosses so that they're aware of it and continuing to teach the class. If it becomes an issue, then doing what needs to be done instead of jumping up and down.
All right, okay. Again, I'm not going to give you the answer to that one. You can think about that one. That'll be one you might likely encounter yourself sometime.
As a student, just been having to find people to report interviews and practice with.
Okay.
It's very difficult to find people I'm not in a dual relationship with.
Yeah. Okay. All right, another one. Therapist living in a small town where there are few mental health professionals. A woman enters service or treatment for depression, but after several sessions becomes evident she's suffering from an eating disorder as well. Therapist has no experience in treating eating disorders, but neither have any of the other therapists in the town, and the closest other referral is miles away. What should the therapist do?
Hopefully learn about something about eating disorders.
Get the textbooks out and read up about it. Okay.
I think you have to be honest with the client about what you do have experience in.
Yeah. That's true, yeah. That sort of reminds me of an old cartoon I saw years ago about the airline pilot. You know, when you're waiting for the plane to get on a plane, and the pilots come by through and they kind of go through to the plane, and this pilot was carrying a big book, and the title of the book was called How to Fly a Plane. How do you feel about flying with that pilot? All right, that's a tricky one, and that's another one that mental health workers have to deal with, particularly in this area of counselling, or in other areas even as well, where you either don't have the expertise or the knowledge about something. Is it ethically sound to suddenly just read about it, or is it better to tell them, which is what you're suggesting, or do something else? And again, I'm not going to tell you what the answer is. Here's a therapist who holds a PhD in psychology, but they're registered as a counsellor. There's quite a few like this, by the way, that you might not be aware of. Rather than as a psychologist, the therapist tells clients at the Christian Counselling Centre where he works that he's a psychologist. Has he acted ethically? You say no? Okay. Why is that? Okay, so registering makes it more true to what his profession is then, even though he's got the qualifications in psychology.
Just with the psychologist, there's a lot more supervisions and you don't know what he's up to in that particular realm, where if he's in the counselling domain, that's what he actually is.
Okay, all right.
Supervised for,
All right. By the way, psychologists aren't necessarily required to have supervision once they're working in that role as psychologists. They are in their leading up to their qualifications, but not necessarily. And if they go for registration, then they are. But it's another interesting one.
You have to be registered to be a psychologist.
You have to be registered, yeah.
Trained, but unless you're registered, you're not actually.
If you want to practice as a psychologist, yes, you have to be registered. Yep, that's true.
So there's probably a good reason why you have to be registered. I don't know what it is, but
Could be.
if he's not registered, then
He might have a shady past and he doesn't want them to know about it. All right, so mental health workers need to understand lots of challenges, including ethical ones, because those are like everyday kind of things that if you're working in this area that you very likely could encounter. And I suppose one of the issues is something that we asked as a question earlier on, is understanding the difference between mental health versus mental illness. And they're often not the same thing, as we've already decided as well. The World Health Organization says there's no health without mental health. So you could have a physical illness. So a lot of times when people get diagnosed with a serious physical illness, they can become upset mentally as well, because it can be quite scary, or might lead to some kind of depression even, because they might be really worried, or anxiety about their future and the future of their family, and so on and so on. So there's a little bit of a kind of a challenge when we think about this area of mental health versus mental illness. So let's do a little quick quiz. Let's say you've got two friends that you go to church with. One is in hospital getting chemotherapy, and the other has been diagnosed with clinical depression. You visit your friend in hospital on the way home and stop to see the other friend as well. So you stopping by and you're kind of talking to both of these two friends of yours. One with, getting chemotherapy treatment, and the other one being treated for clinical depression. So the quiz would be, you give comments to both of these friends that you visited. Comment number 1 says, you say, stay positive and things will just be fine. Comment 2 is you say, stop feeling sorry for yourself. Get up and get over with it. Get on with it. So which do you give to the friend with cancer, and which do you give the friend with depression? Neither? Okay. Other thoughts?
definitely not the second one.
I think both comments can come across condescending in some ways. Like, I don't know, you're talking to someone who's suffering with something really well, you could be standing there completely healthy physically and mentally. But it just kind of doesn't seem like you really understand them, you're just kind of giving a comment.
Okay. Any other thoughts?
I think that with the first comment, when you've got depression, or even with both of them, you don't want to hear, stay positive or stop feeling sorry for yourself. You've got an illness that needs to be medicated and to be cancelled through on whatever to get you back into a good place.
Yeah.
Where with a cancer patient, well, stop feeling sorry for yourself really seems inappropriate. And stay positive seems to be fine. Although it seems cliche, and I think that you're better just being present in the moment than what you are trying to, either, I guess in a sense, sound heartless, because both of those in each case sounds like there's no thought from you.
Okay. I guess one of the things to think about is that you guys are all sort of been studying some of this already, but for people in our general population who had those two friends, would they be thinking as kind of clearly as you all are, because you've read some textbooks already and you've done a little bit of studying in this area, because it's an issue that we see happening in the real world, unfortunately. So imagine what it would be like if we treated everyone like we treat people that have a mental illness, for example. So, heart disease is just another excuse for lazy people not to work. Do they say that about people who might have mental health challenges or illnesses? Sometimes, yeah. Particularly people with depression. I know a young man in a church in Toowoomba a few years ago this happened. He was disfellowshipped from his church because he was lazy. Because they would have a working bee and they would invite everybody to come down to the church and they'd do all their cleaning and the things a lot of churches do. But he would come and he would sit around and he would be like lethargic and say, "Oh, I can't do that." Pull yourself together, man. He ended up taking his life. And when he died, they found that he had a brain tumor that no one knew about. That's the real world. Well, how about a lot of people get cancer because they just can't deal with reality? The reality is that sometimes people with mental health issues are not treated very well at all. So if you're going to work in the area of mental health, your ability to understand mental health and mental illness is a really, really important part of your journey in terms of working in this area. So there's a kind of continuum here. On this top area, we've got maximum mental health, minimum mental health, and maximum mental illness and minimum mental illness. So in this bracket over here, the diagnosis of a serious illness but copes well has got a positive mental health. So their mental health is like they're optimistic that they're going to get better, that things are going to improve and it won't be too bad. And that's important to realize that we're dealing with these two kinds of continuums. One is a mental health continuum and the other one is a mental illness continuum. And sometimes they're overlapping. And our challenge is, well, can we kind of discern the differences and can we be aware of the differences and then being sensitive to those differences as well. I might ask you all to stand up. Now, Johannes and I are already standing, so this might be a little bit tricky, this little exercise, but what I'm going to do is I'm going to ask some of you to sit down. So you can sit down, you can sit down, you can sit down, you can sit down. So how many is that? 1, 2, 3, 4 sitting down. The problem is we should have had 10 in here. So we'll pretend somebody else is sitting down. There were 10 people in this room. You have another person in this class who's not here today. So let's pretend he's sitting down. It's a he, isn't it? The rest of us would have mental health issues. Roughly 1 in 5 people have mental health issues. 1 out of 5. This is the percentages. 1 in 5, 20% of people in the 16, you can all sit down, sorry. In the 16 to 65 will experience a mental health illness in Australia. In the 16 to 65, over your lifetime, about 45% of people will have some mental health challenge or illness.
How much has that increased over the last century?
How much of it has increased?
Yes, what would that be different?
Well, the reason why, it would have increased, but the reasons why is probably because we've got better diagnostic ways of figuring it out. We keep better research statistics. So it's hard to say, you know, there would be probably some because our lifestyles have become more stressful and so on, but the reality is that it probably has gone up, yeah. But as to the reasons why, that would be kind of debatable. So when we think about mental health issues, generally we start looking at symptoms that are sort of outside of our normal experience. So getting into the realm of things like anxiety, some depression, and so on. So, you know, I guess one of the things about depression, depression is, by the way, the common cold of mental health. And that really is the likelihood that most of us have all had depression of one sort or the other in our lifetime. So that morning when you have to get up to go to work or go to college and you feel like, oh, I don't feel like it today, and oh, I'm so bogged down with assignments, and you might feel a little bit blue. That's a kind of a mental health type issue that you're having at that point. And that's kind of low type depression, if you like, in a way. And when we look at depression, for example, the reality is that we all probably, like we all get colds in our lifetime, we all are going to experience some mild type of depression or maybe severe type of depression. So you can see it kind of like on a continuum from the mild area down here to the chronic area down the other end, when it becomes, you know, quite severe depression, people become immobilized. Somewhere in the middle is kind of what they would describe it as medium. So it's not, you know, down this end you probably are coping reasonably well until about that point over there on the scale. But from this point over here, just before the medium starts, this is when we enter into the realm of what is known as clinical depression. And clinical depression can be debilitating and it's progressive. It's sometimes, if it's not treated in some way or an intervention isn't being made in an appropriate way. All right, so in the mental health area, you're going to see people like this. If you work in a Christian environment, there's another challenge there as well, because in my lifetime in working in Christian environments as well, I know that there are some Christians who don't believe in depression. So those little quotes we saw there about pulling yourself together, I've heard, you know, people being told by their pastors, you need to be praying more. How many times are you reading your Bible? Oh, and only once. Well, that's the problem. You need to read your Bible every day.
Where's your faith?
Yeah, where's your faith? Yeah. So the reality is that we need to realize that when we're working in this area, it's an area that we're going to be dealing with. And this is probably going to be the most common area because depression is the common cold of mental health issues or illness. So when we define mental illness, for example, the definition here is quite an interesting one. It says a term that refers collectively to all diagnosable mental disorders. Mental disorders are health conditions characterized by alterations in your thinking and your mood, or your mood is kind of describing your emotions, if you like, and your behaviors. That's a key thing. Another way of putting that sometimes is a reality that all people have thoughts, feelings, and actions. So whenever we're talking to another person, that's what we're looking at all the time. We're looking at how's this person thinking? What are their emotions? And what are they actually doing? How are they acting or how are they behaving? And all of us have those. If you're a human being, we all have thoughts, feelings, and actions. One of them is stronger than the other. One of the tricks for mental health workers to be aware of is that if you are more of a thinking type person, and then secondly, you might be somebody who likes action, you know, you like to get into things, and then your weakest point in your own personality is being in touch with your feelings. So if that's you as the helper, I'm going to use the general term over there, or mental health worker, and you've got a person that you're helping whose profile is a little bit different. Let's say they're big into their feelings. Emotions are just gushing out of them. And secondly, they are thinkers. And then lastly, they're action people who kind of, lethargic in doing things. The temptation for you as the mental health worker is your ability to say, well, where am I most comfortable in? Well, I'll aim at this person here in the thinking area. But you might not be very successful in helping them in that area. So one of the challenges in mental health or working with other people is to start to begin to train yourself to become more aware and trying to assess where is this person kind of dominating from. And there are some areas in psychology you can learn by listening to the language of people as to where they might be more dominant in those areas. So the trick is for you to adapt in your weakest area to kind of really work with that person, because that's where they are mostly coming from. So how can I then adapt to their area? And if you're not able to adapt, then it becomes an ethical issue as well. So that's where again you might say, hang on, I might not be the best person to help this person. Perhaps it might be appropriate if I refer them on to my colleague who works more with people with emotional type areas. Does that make sense? Does anybody have any thoughts or questions you want to ask about any of that?
I guess that applies to any kind of social work that you're doing.
Pretty much, yeah, pretty much. When you're dealing with other people, we're all different, we're not the same. And so the temptation is to see other people the same, or to judge other people the way we have judged ourselves. And the reality is we have to see that other people are different. And the challenge is, can I understand the other person rather than me understand myself? I think it was Francis of Assisi who had his little prayer that said, seek to understand rather than to be understood. Because a lot of times we want other people to understand us, but we're a little bit reluctant sometimes to take the time to understand another person. So some of the skills that you learn in mental health and counselling is listening skills. How can I listen to that person? So when I'm listening to them, I'm listening to kind of find out what are their thoughts and their feelings and their actions. And that's a key part of understanding a little bit about mental health and mental illness. So when we look at the sort of Bible, if you like, on mental illness, the DSM-5, Diagnostic Statistical Manual, which is where they define mental illness, there's a range of subjects, and each one of those has got a breakdown of something else further.
Do you think that as time progresses, since autism and ADHD type conditions come under the DSM-5, that they will come back over to mental health categories instead of disabilities, or?
I don't know. Look, the DSM-5, one of the things I know about it is it's not set in concrete.
True.
Again, it's a social science. Psychology is a social science. So as a social science, it's not an exact science. So they change every now and then with either new awareness or new understanding or, some new debate even, or whatever becomes popular. For example, we're up to the DSM-5, but in the DSM-3, so this is going back quite a number of years now, homosexuality was defined as a mental health issue. But it isn't anymore. In the last DSM, when they brought that out, there was a big debate going on as to whether sexual addiction was an addiction or not, an addiction issue. So the DSM recognises substance abuse addiction. So if you're a person who takes drugs or alcohol in a big way, it looks at that area, but it won't look at things like non-substance addiction. So if you're a gambler, or if you're a sex addict, or a workaholic type person, it doesn't look at that. And yet, the argument would, on one hand, would be, well, there's no substance involved, and yet there is. What's the substance? Who can tell me what the substance might be? There is a substance, but it's not an obvious substance. It's the stuff in your brain. Things like dopamine in your brain is what really drives us to make different choices and do certain actions and things like that. So we can become addicted to that hit of dopamine in our brain as well, which is really a substance as well. But in the last DSM-5, they decided no, they would reject those as being actual addictions. And yet if you work in the area, you know they are addictions. I mean, one of the areas that when I was working in the clinic here in Mount Gravatt, I used to see a lot of people who had sexual addictions. And it's no different to a drug addiction. The behaviours are very similar. So, and when we're assessing mental illness, there is a kind of subjective value, information that comes along. So that's the kind of lived experience that's based upon knowledge from the person and the family. So when you're talking to somebody with an issue in a mental health area, you're kind of wanting to find out collaborative information about that person. How do they live? How do they work? What do they do? Etc., etc. There is objective type information where you might use a tool to kind of measure the condition of that person. And then there's the clinical reasoning. So clinical reasoning is based upon your experience in working in that area. And as you gain more knowledge by working with people that might have that particular condition, that gives you a kind of a clinical edge, if you like. But you're also relying on those other areas as well to kind of come up with an assessment of what that person might be. Now, as a mental health worker, when I was running the clinic in Mount Gravatt, we would use all of those as a way of assessing people when they would come in. So assessment includes things like the interviews, questionnaires, information from other sources. So sometimes we go to schools and we go to doctors and other people that they might have seen, other professionals, and then we kind of summarise and formulate an assessment. But assessments are not 100% accurate as well. They kind of change as well. There was a very famous case in New Zealand, 15 years ago. They made a film about it. It was called An Angel at My Table. Have any of you seen that or heard of that? I never remember the lady's name, but it was based upon a New Zealand poet, and she was quite a famous poet. And she behaved rather badly and would do some pretty, crazy things, I guess. And they reached the point where they were going to do a lobotomy on this person. And the doctor, a lobotomy, you all know what a lobotomy is? It's where they remove part of the brain. They were going to do a lobotomy on this person. This isn't that long ago. They still did it in New Zealand about 15 years ago, when the doctor who was going to do the operation looked at her and he said, "Oh, isn't this that famous poet?" And he said, "No, I can't do this." He said, "I don't want to do this because that would take away something from who she is." And this particular doctor was the first doctor that really did some serious investigation in this person's life. She had been assessed and labelled as somebody with schizophrenia, living with schizophrenia. When this other doctor who was going to do the lobotomy looked at her and realised, hang on, no, she doesn't have schizophrenia. She'd found that she'd been severely traumatised in her life, had been abused severely in her life. So some of her behaviour was coming out of her traumatic type experiences that she'd had in her lifetime. So while we use those assessments in mental health areas, they're not absolute. So it's always a kind of an area that you want to be aware of as well. They're helpful guidelines. I wouldn't take away from them, but to realise that you need to keep an open mind about what a person might be labelled with as well. And there are some people now who would advocate, and the main criteria often comes from that DSM. So in mental health, we don't generally kind of use them very much. And really, it's only the psychiatrists who are qualified as mental health workers to kind of use that as a tool. As a mental health worker, when I was working full-time, I would use it only as a guide, to kind of guide me to kind of see, hang on, there's this possibility or there's that possibility as well. So the diagnosis versus mental health versus mental illness is often to do with, the duration, the frequency, the impact that that person might have, and then finally diagnosed by a professional that's qualified to make that diagnosis. And generally, only psychiatrists can make that diagnosis. And again, having worked in the industry for years myself, The reality is there are good psychiatrists and there are bad psychiatrists as well. By the way, excuse me if I do get a phone call, I'm actually expecting a phone call from somebody, so I hope you don't mind if my phone does ring, because I'm expecting a phone call myself. That's an important one. So yeah, those are the areas there. The qualified professionals who might help might include in the mental health area, psychiatrist, paediatrician if they're looking with younger people, your GP. Sometimes GPs are, they kind of include themselves in as mental health workers as well, although that's not their primary role. They are, in a sense, mental health workers because they're looking out for the mental health as well as the physical health of people that are their clients. Psychologists, little asterisk there by the psychologists. And then mental health clinicians. These are people who are authorised, someone like a mental health nurse, a social worker, occupational therapist, and clinical counsellors. The little asterisk means that the diagnosis is likely to be provisional. So someone in those categories might make that assessment, oh, this person might have this kind of condition, but the final person is really the psychiatrist who calls the shot, who says, yep, this is really what might be happening for this person, or not. Does that make sense? Yeah?
What's the difference between a clinical counsellor and a counsellor?
A clinical counsellor, when you join one of the associations like PACFA or ACA, they have different levels, and the top level in PACFA is the clinical counsellor. So this is someone who's gone a little bit further. They might have also done the course in mental health as well, which is what I had done myself as a social worker. I had to do that extra mental health kind of part of their course to do. So, but it's generally by the degrees from the accredited organisation. Yeah. So you all know about PACFA and ACA as well? Those of you who are going to be counsellors? Yeah?
I haven't learned it, but I have prior knowledge of it.
Okay. Well, PACFA is probably the umbrella type organisation for people working as counsellors. And the way they've been operating, although I think they're in the process of changing it, is they like the umbrella organisation, and then they have a whole lot of other little smaller organisations that are part of their overall umbrella. So you become a member through that channel. And Christian Counsellors Association is one of those member organisations that sometimes people working in Christian areas go through. So how do you become a mental health worker in Australia? How do you do it? Those of you who thought, that's an area that I might like to work in mental health. What's the way you go about it?
You need to get like a qualification.
Okay, yep.
I'm not sure whether it's like you just need a diploma or if you need like a whole bachelor degree.
Oh, you need more than a diploma, I think. Yep, yeah, at least. Preferably masters, and it's changing all the time. They're kind of upping the ante all the time. Yep, what else? Any other thoughts?
It would be depending on what you were looking at, whether it be like psychology or psychiatrist. Would that be different?
What is the difference between a psychiatrist and a psychologist?
One can prescribe medication.
Psychiatrists can prescribe medication. Why?
Because they have
Because
medical
they're
degree.
GP and medical.
They have medical degrees. But did you know that in the United States, in some of the states in the US, they now allow psychologists to prescribe medication too? They want to do it here, but there's been people fighting against it, and I think rightfully so. But psychiatrists usually start out their journey in life, in their training, as doctors, general medical doctors. So they'll do a general medical degree, and then they might somewhere along in their medical degree think, oh, I'd like to specialise in, looking at more about the brain and the mind and stuff like that. So they do extra training, if you like, in psychiatry. And then they become psychiatrists. But primarily they're medical doctors. So one of the problems that I've had with psychiatrists over the years, not all, but quite a few, I have to say, is they still think very medical. In other words, and medical doctors think what mostly? Yeah, bodies. You know, there's something with your body and something wrong physically as well. Yeah. So they tend to be more kind of very objective in that sense in terms of looking at the body, and kind of don't always look at the bigger picture sometimes, is what I've found. Over the years, I've probably encountered, on two hands, maybe 8 psychiatrists that I really got to trust and kind of rely on, but a lot of them I found were often very just diagnostic in their way that they handle people, and very objective and not looking at people in a deeper way. But not all. So that's, I don't want to generalise to say they're all like that. Yeah. So anything else you want to add to what might be involved in becoming a mental health worker? So it depends what pathway you take. So you could go as a doctor, or as a psychologist, social worker, nurse. Some nurses go into that area, clinical nurses. What else? I think the key is about where you go. So you might get your primary degree, say a bachelor's degree, but then you might have to do some extra training, if you like, to qualify to go into the mental health area. They've got...
Would that be specific to the organisation?
It might be specific to the organisation. The organisation might require that, but it would depend on whether you then can practice in that way as a mental health worker. Because again, you'd want to protect yourself. If you're making decisions or assessments that are, you know, something that a mental health worker would make, you want to be qualified to be able to make that kind of assessment reliably, so that people don't come back at you and then point the finger at you. Yeah. Does that make sense? Yeah. All right, any other thoughts? All right, let's just have a look at some of these things. So mental health workers are people who work to improve the quality of health by resolving psychological issues, primarily. They deliver counselling, they refer patients to other social services. So again, it's that ability to realise this is outside of my realm of understanding or scope of what I know. I need to perhaps refer this person on to somebody else. So they see clients from a range of areas, so covering anxiety, depression, post-traumatic stress disorders. The primary focus of mental health workers really is supporting their clients in addressing whatever their mental health issues might be.
So you would need some kind of counselling qualification?
Counselling certainly does help. I mean, even those who come from a nursing background often have counselling as well as part of their initial training. Social workers do as well. So yeah, you do need some, because the counselling gives you the edge of learning how to listen to people and how to kind of, you know, make that connection about what's going on in the life of the person, really. Okay. So basically what you're doing is you're assessing clients and monitoring their progress, maybe as a mental health worker. You might be delivering counselling either to individuals or into groups. In our service, when we ran the service in Mount Gravatt, we used to have a lot of group counselling as well. We actually had a group that was for depression, for people who were experiencing depression in their lives. We ran an anger group, so people that had anger type issues. We ran a couple group for people who were going through relationship difficulties. And relationship difficulties, while it's a relationship issue, often generates mental health kind of issues, because it can affect the stress from the relationship, can cause you to have all sorts of other things like anxiety and commonly depression as well. You're liaising with other community and social groups, and you might be developing mental health programs or plans. So running groups, which is what we did, to help those people that came to our service for help, we would often then perhaps refer them to a group to get extra help, if you like, as well. And obviously you want to maintain client records. So the client records are important because they become an ethical issue as well, to make sure that you've got reliable information, that you've kept accurate information about the person as well, and what's happening for them. So being a mental health worker is really one of the things, if you like, these are a kind of essential things that I think are important, is you want a comprehensive understanding of mental health issues. So in order to work in this area, you probably need a little bit more training in the area of mental health and mental illness, even in understanding mental illness a little bit. Now, one of the things this college has done just recently in the last few years, and it was one of the areas that was lacking, unfortunately, was that if you study as a psychologist, for example, you do a subject that's called abnormal psychology. And abnormal psychology really focuses in on all of the really stressful, severe type conditions that people might develop that are often related to mental illness type areas. Counsellors generally didn't. But I think the college now has a subject that covers a lot of those areas, and they were kind of forced to do that by PACFA. Because one of the things that's been happening in PACFA is getting people to kind of to become registered so that they can get a provider number through the government, so that people can get a relief when you get a referral by a doctor. And so they've kind of said, well, look, if you counsellors want to be in that way, you've also got to do a little bit of work in the abnormal psychology area. So Heritage now have a subject that covers those areas as well as part of their normal degree, which is a really good thing. Because the one thing about the difference between the two is, again, it's like you've got a bit of an extreme as well. You've got counsellors down this end, and you feel like you've got psychologists down this end. And counsellors tend to be those who are kind of more practitioners, if you like, I could put it. So practitioners, and psychologists tend to be more scientists. Why do you think that is? So we've got this little bit of continuum. Why do you think that might be? Well, psychologists study more. They have a bigger subject generally than most people would cover in a normal counselling degree or a social science degree. Science, on the counselling side, they cover more sort of evidence-based type areas. And one of the things that's happened in the mental health area, for example, it's slowly kind of creeping here in Australia as well, but in the United States, where counsellors can be registered as mental health workers a little bit easier than they can over here, and they can claim their relief with the insurance companies and so on. They can only do that if they are using an evidence-based practice in their work. So they've got to be doing things that can be proved to work scientifically. So in other words, if they want to use something like psychoanalysis, which isn't an absolute evidence-based practice, they would say, look, no, you can't use that. So it's starting to happen in Australia as well, where they're encouraging people to use more evidence-based practice. So if you work as a psychologist in Australia, you have to use evidence-based practice. So you've got to use things like CBT and things that they can measure and say, yeah, well, that works or that doesn't work. Does that make sense? Yeah?
Psychologists work more with the diagnosis of what is the issue as well, or so other counsellors?
Could be, yeah. What? Yeah. Yeah. For me, they both need to kind of move more closer to the middle, really. I think rather than being on the two extremes, it would be nice if we could move a little bit closer to the middle. Because the one thing that practitioners at the counselling end do, they're very good at listening, and psychologists are very good at making diagnosis, but not very good at listening. So it would be nice if we had a kind of a merging, I guess, between the two, somewhere in the middle. So, but guys, what I'm saying with this one is about, if this is an area that you want to work in, you do need to maybe do some extra study in the area of mental health and mental illness. And there are a few good courses around. Some of the organisations run regular programs on mental health issues. You can do courses through Headspace, run a few training programs as well that you can look at as well. You might want to look at those, and I saw that on your board from yesterday, so that's something you would have touched on yesterday. The government run a couple of courses every year as well in this area too that you can be aware of well. I've got a link to it a little bit later on one of my slides. You definitely want to have some people skills. So people skills are skills that allow you to kind of connect with other people, to kind of make that connection so that you can engage at a human level and not just be kind of robotic, if you like. You want to be able to engage at a much more intimate kind of a level to understand what's going on in that person's life. One of the things that the college have been using here over the years that originally came from John Warlow is what they call the CURE formula. And the CURE formula is quite a good way of understanding what happens in counselling. The C stands for connect. So when you're engaging with a person, you want to connect with them. You want to build rapport, you want to build understanding, you want to kind of make that relationship so that that person feels comfortable in talking with you and disclosing what might be happening in their lives. So that connection is really an essential ingredient of working as a skill with people. The second thing, the U stands for understand. If you don't understand what's going on in the life of that person, then it's pretty hard to help them. So understanding takes time. It's not something that happens straight away. It means that you are really taking the time to really listen. It means that you're really acting as if you don't know. So have any of you seen the old TV detective Columbo? Remember Columbo? Just some of you are shaking your head, some of you don't remember it. He's too old. All right, he was a detective that they used to have on TV a few years ago. And everybody used to laugh at him because he was kind of like, doesn't this guy know what he's doing? But he used to act dumb. So when he was kind of solving the crime, you know, people would tell him things and he'd say, look, I just have a hard time understanding that. Can you just go over that again and maybe just tell me what you mean by this? So he was quite a curious guy. So because he would ask those kind of questions, people would look at him and say, oh, this guy's an idiot. But what they didn't realize is what they were disclosing lots of information about things that they've done that they hadn't disclosed before. In counselling, that's a good skill to have. You want to be curious. In helping people in the mental health area, you want to be curious because you don't know. So your ability to know, to understand is a really significant aspect of being a mental health worker, an effective mental health worker. Make sense? Yeah? Because one of the problems with the R, what do you think the R stands for? How many of you have seen the CURE formula before? This what? No.
Okay, I thought it was because you said it earlier.
No. Rapport comes in connect. You want to build rapport when you're connecting.
Yes, recognize.
No.
Refocus.
No.
Respond.
Respond, yes. What am I going to do to help this person? What can I do to help this person? Let me think. I've got my bag of tools over here of all my skills I've learned over the years. I've done some CBT, I've done some narrative therapy, I've done some, different types of counselling. Which one should I take out of the bag to use with this person? So it's my response, my intervention. So what am I going to do to kind of help this person? The problem with lots of people who are beginning in the area of counselling is they go from there to there and they bypass understanding. You can't help somebody and respond effectively unless you understand them. So that's why the U in helping people in this area is so important. Does that make sense? Yeah? So it's about your ability, first of all, to connect, understand, and then respond. It's quite easy to respond, and one of the things that you might have noticed in your life too, when you go and tell somebody something that a struggle you're having, they'll say things, you could have done this, why didn't you do this? Well, maybe there's some things they didn't know about the story yet, because they haven't listened to your story well enough, so they don't understand what your story really is all about. So responding comes after connecting and understanding. What do you think the E stands for?
Engage.
Evaluate. Yes, evaluate. Am I on the right track? Am I doing the things that are going to be most helpful in helping this person with whatever their concern might be? E is actually two things. There's another E. So evaluate is one E. What do you think the other E might be?
Assess. Oh, that's it.
No, that's an A. it's engage. So it's a part of the response area as well. Do I need to engage another professional or another service in order to take this person further down the track? So this might be outside of my scope of area or understanding or expertise. Do I need to engage other people? Do I need to engage maybe the community to be able to help this person more as well? So having people skills as a mental health worker, really, really paramount, essentially. Yeah? Mental health workers need to have a strong problem-solving skills. In other words, you need to be able to look at this and make an assessment of where you're going. And when you're doing that, you can use this kind of formula as part of that journey as well, of connecting and understanding and then responding and engaging and evaluating where you're going as part of your ability to problem solve, to kind of think through things as well as you're going along the journey. And they should have a good understanding of the roles and functions of the wider health and social services. So what is that wider health area that I'm working in, where perhaps may be appropriate that I can refer this person to as I engage perhaps other professionals or other sources that might be able to help further down the track. Yeah? Okay, any other thoughts? We might take a little break at this point. Before we have a break, any other thoughts, comments? Okay, let's take a break. We'll have about 20 minutes. It's about 10 past 10. I'll see you back here at 10:30.